Thank you for being here in such large numbers, and I really hope this meeting is proving useful to everybody. Let me honestly share the inner dialogue that goes on whenever we are planning a surgery. Have I actually completely seen the disease in my mind's eye? Have I imbibed all the imaging details? Do I have a complete plan ready for the excision? These are very basic questions that we need to put to ourselves every time we take on a patient. And this is the kind of mental process that goes on when we are deciding to resect a patient of this large a malignancy, which unfortunately is common in our situation. That brings me to a quick slide on what should be the strategy for the primary and what are the determinants. We need to completely understand the area, the depth of the excision necessary, the critical soft tissues that will come in the path, which is nerves, vessels, ducts like the Stenson's duct, muscles, critical bony areas, critical regions close such as the lips, the tongues, the retromolar trigone, the intratemporal fossa, and most importantly, local background conditions such as submucous fibrosis and trismus. And here we need to evolve an excision design which involves an incision plan and an approach. And to just give you a sense of how all this comes together in a patient, and I think that it's all context. It is the context that we are talking about. And I think the context that we all need to think about, and I think from Dr. Shah's inspirational talk, we know the context is not just restoring aesthetics, but restoring function. We need total functional and aesthetic restoration in every case and aim towards it. Excision with reconstruction in mind is science and art combined. Excision without reconstruction is mindless butchery. So thank you very much for your attention.